All right, so our next presentation is Indigenous Engagement and Action Lessons from IPERC and the Kidney Check Project. So I'm pleased to welcome our next two speakers, Cathy Woods and Tannyce Cook from the Cansolve CKD network. Cathy Woods is a patient partner of the Cansolve network and a member of Naicatchewenin First Nation in Ontario, now living on Treaty 1 territory in Winnipeg, Manitoba. She served as the founding co-chair of both the Cansolve CKD Patient Council and the Indigenous Peoples Engagement and Research Council, and still serve on numerous committees and working groups advocating for awareness and improved kidney health for all. Cathy is the patient partner lead of the Kidney Check research project that seeks to screen and triage Indigenous people living in rural and remote communities within Manitoba, Alberta, and British Columbia. Tannyce Cook is a Cree and Métis nurse from Manitoba whose father was from Misipawistik Cree Nation and whose mother is Métis from Matheson Island. Since becoming a registered nurse in 2011, she has worked with First Nations communities and across Manitoba, focusing on diabetes and kidney health screening and education. Through her work with the Kidney Check program and sitting on the Cansolve CKD Indigenous Peoples Engagement and Research Council, Tannyce is committed to advancing culturally safe care, strengthening Indigenous engagement in health research, and improving health outcomes for Indigenous communities. She is a passionate advocate for Indigenous-led approaches to healthcare and research, grounded in respect, relationship building, and community connection. So I would like to hand it over to you, Cathy and Tannyce.
Thank you.
Hi, everyone. My name is Cathy Woods. My traditional name is Naicatchewenin, which means a circling golden eagle woman. I'm a member of the Bear Clan and a member of Naicatchewenin First Nation in northwestern Ontario. I now live in Treaty 1 territory in Winnipeg, Manitoba, and I am I'm the co-chair of the Indigenous Peoples Engagement Research Council. And I'm also a national patient lead on the Kidney Check program, which we'll be talking about in the second part of our presentation. And I'll turn it over to Tannyce to her introduction.
Thank you, Cathy. My name is Tannyce Cook. I'm the director of the Diabetes Integration Project at the First Nations Health and Social Secretariat of Manitoba. And I'm happy to be here today to present about our kidney health project.
Next slide. Before I start, I'd just like to acknowledge that Tannyce and I are coming from Treaty 1 territory in Winnipeg, Manitoba, and also the homeland of the Métis. I'd also like to acknowledge too that our water source comes from Shoal Lake 40 in Ontario, and our hydroelectricity comes from Treaty 5 territory in northern Manitoba. And speaking of the water source, we got really bombarded last night with a torrential storm and some tornado watches and warnings and stuff. It was kind of a scary time. So, but today we're all good and ready to move on. So, in this session, we'll cover the ethical and community-driven Indigenous research, engagement in research. We also will talk about community voices in kidney health. We'll talk about the lessons that we've learned in terms of cultural partnership and cultural safety. And we'll talk about community-driven and Indigenous-led approaches to kidney research and care. Next slide, Jocelyn. So why this conversation matters. One of the things that we found out quite early when we first got involved in Cansolve CKD was the disproportionate burdens of kidney disease and organ failure within the Indigenous community. And we also have ongoing inequities in terms of access to not only culturally safe transplant and donation services, but also access to care in terms of being able to, for rural and remote communities, just being able to access primary care in Manitoba is of great concern. We also understand that research systems have not always reflected Indigenous priorities or experience. So what we are, Cansolve was launched in 2016. It's a national network that brings together kidney patients, researchers, healthcare providers, policymakers, and caregivers. You can see the map on where we are placed in terms of how many people are involved in the amount of money in terms of research and all of those things that we do. I was involved in 2015 in the prioritization project of looking in our first phase one of Cansolve. We had 18 projects, and in our phase two, we ended up with 9 projects. And now we're in the knowledge mobilization and knowledge sharing of all of the projects that we've worked on, and we're working on. We also have our impact and our impact statements that keep us moving forward in terms of what we've done. So what is the Indigenous Peoples Engagement and Research Council? It serves to guide the conduct of the network activities in accounting for the unique aspects of patient-orientated research involving First Nations, Inuit, and Métis. When I first got involved, it was about helping me and my colleagues to find our voice and to know that when we came into research, that our voice and our advocation and what we did was very important, and that it needed to be heard because of the lack of Indigenous people involved in research. And so we support Indigenous perspectives in research and respectful partnerships with Indigenous people and communities. We've also developed resources, many resources that we have. You can see the link on Cansolve CKD, and we'll further go through some of the resources and things that we have to support culturally safe and appropriate services for Indigenous people. One of the things that we've developed with our knowledge keepers in research was Indigenous measures of success. And as you can see, it's quite a unique document in terms of what we do. And what we found was that we needed a two-eyed seeing approach in terms of looking at Western science and an Indigenous approach. And one of the things that I found early on was that in research, it's about the numbers. It's about, how many people you screen, how many people you access, all of the data, which is very important to research. What we found in our communities that it was distinctly different in terms of how we looked at research, and that when you were involving one person in research in a community, that were only involving them, you were involving the whole community, and you were involving their family, and you were involving their caregivers. And so we needed to create a model and a toolkit to be able to help non-Indigenous researchers to understand that it's not always about the qualitative data, that it's more about the quantitative data and what it means to the community. And I was very fortunate in my journey. I had kidney disease, developed membranous nephropathy in 2010. And I was successfully treated in 2012. And I used a combination of Western science and Indigenous. I had a group of elders that worked with me. I had Indigenous medicines. I had lots of ceremonies. And I had a whole group that continued to support me and still support me to this day. So from that perspective, Western science learned that to incorporate traditional medicines into how we heal and how we see everything in a holistic way about mind, body, heart, and spirit, and to keep working on those things. And having that two-eyed seeing approach is something that's always really worked. One of the other things that we really found out quite early in our journey was that in terms of working with communities and working with us as Indigenous people was that we didn't want to hear about the statistics and how bad they were in terms of kidney disease and that we wanted and the community clearly told us that they wanted us to help them to get better. So we incorporated a braid of wellness into everything we do. And one of our early colleagues that has since passed on talked about, please don't tell us how sick we are, help us to get well. And so we learned that early on. And so almost in everything that we do is that we talk about wellness. One of the other things that we learned quite early on was that to address some of the gaps and try to address some of the gaps in terms of colonization and health access to care is that when you're doing kidney screening and different things and kidney research, it you just can't tell people that live in northern and remote community, to eat more lettuce and greens and things like that when there's an issue of food sovereignty and food access to care and how to do that effectively in terms of things. And for us that live in urban communities, it may be easier because we have access to food. But when the access to food is limited, in terms of you have to look at traditional foods and you have to look at different measures of how you can help the community. And we also, through the Indigenous measures of success and working with communities, we're able to start creating an awareness of kidney disease. And I'll admit, in terms of when I first started 11 years ago, that awareness of kidney disease and its prevalence in our community was clearly not understood. And it really we needed to create that awareness, but we needed to create that awareness in terms of the language to be able to make sure that it was accessible, to make sure that people understood what we were talking about in terms of the signs of kidney disease and the risk mitigation strategies that they can use in terms of lifestyle, in terms of drugs, in terms of that. And right now, within kidney disease, there's also a large number of new drugs, 4 classes of new drugs that are out, that we give that information to the community. And some of these drugs have been proven to delay the onset of the need for dialysis and to actually extend the life and how to do those. And so we needed to give that information to communities so that when they were in contact with the healthcare system, that they were able to find out if they were able to take these drugs and how they would work better for them in terms of that. So for me, it's about the awareness. It's about working with community. It's about continuing on and helping the community rather than shaming the community for the burden of disease that's happening in the community. So this was a really good lesson for our non-Indigenous researchers in terms of what we do. And one of the things that we ask for our researchers is that we have a model of what we call our learning pathway. We ask them to take that model for them to help understand the effects of colonization on the Indigenous community and how to move forward in a good way. So some of our impacts, one of our members, Tamara Beardy, that lives in Winnipeg, went on a 90-kilometer journey to be able to create that awareness in terms of that. We have our Knowledge Keeper, we have our video series, and if you go on our website, we also have our storytelling module. We have our land acknowledgement series. We have our ethics, research and ethics in Indigenous communities. We've also participated and done many different papers in terms of setting examples. One of them was ensuring Indigenous co-leadership in health research, a Cansolve CKD example. So that we have lots of different publications and things that we've been part of. And so we hope to keep that learning curve and keep it moving forward. So I talked briefly about our learning pathway to enhance the knowledge and awareness of the racial biases We also have Indigenous Voices and Stories, the impact of colonization, and culturally safe healthcare practices. And so, as you can see, we have the land acknowledgement series. We do the Karis blanket exercise. We have Sanyas training, which is actually Sanyas training is different in every province. It is very much, they use the people of that province to be able to create the story. We also have the knowledge keepers. We also have OCAP training. And we also have our cultural competency knowledge bundle that we use. And then we also have our video learning series, Misipawistik, which is health, wellness, and well-being. It's designed to be culturally relevant for Indigenous people. It consists of 9 modules on kidney health, from kidney function to treatment options. I urge you to go on our site and look at all of the resources and things that we have available. So before I hand it over to Candace, I just want to say that I am the national patient lead on the Kidney Check program, and I've been involved from the very beginning in the Kidney Check program, and it's one of my greatest experiences that I've had, and I will continue to work on Kidney Check because as someone who was screened early and with aggressive medicines and traditional preventive medicine, I was able to be well, and I've been well since 2013. And I believe that it's my obligation, and I'm blessed to be part of this, to be able to ensure that kidney screening is available in rural and remote communities and for all Indigenous people. And I will turn it over to my partner, Candace, my partner, Tannyce, to be able to further evaluate on our Kidney Check program.
Sure. Thank you, Cathy. So with the Kidney Check project, it was a screening program based on the finished project that FINISM had undertaken back in 2015. So we knew that there was really high numbers of kidney disease in Manitoba, but we didn't know really what the numbers were. So that finished project gave us kind of an idea. They were able to find some people who are really in need of some kidney care, who are high risk or medium risk people in the western part of Manitoba. So based on that project, once the Cansolve Kidney Check project came up, they partnered with the Diabetes Integration Project to do the screening because we had that experience in Manitoba already. So one of the screening project or the screening appointments that we have, the results are in under 1 hour. So we can take a small blood sample, small urine sample, and using our point of care machines, we are able to let you know your risk of needing dialysis in the next 5 years. So then that's within an hour. Looking at the results, we're able to kind of personalize where they're at with their kidney care and what kinds of changes they can make. On a medium or high risk, they're directly referred to Dr. Comenda, a nephrologist here in Manitoba. So getting that treatment early, you can really help to prevent and delay dialysis, especially with the medications that Cathy had been talking about earlier. So we spend some time with them once we get the results, and we make a personalized health education and plan with them. We give them a little pamphlet with just some things that they can do, small things, realistic things that they can do to improve their kidney health and improve their overall quality of life while remaining in their home community. So we know that the kidney screening, just the amount of money it costs to have somebody on dialysis, just finding 1 or 2 people and delaying the onset of dialysis, you're looking at millions of dollars saved. So in Manitoba, we have got into 10 First Nations communities and screened over 700 people. We had partnered with the Prairie Mountain Health Region, who had done they had the machines and the people available to actually help us out and do some communities so that we could get into more First Nations communities and screen as many people as we could. And we also had the virtual kidney check project, which is looking more at kidney screening as a public health thing where you would get a letter in the mail. We looked at 4 communities, looking at everybody who was eligible for kidney screening who hadn't had a GFR test done in the last couple of years, and we sent them all letters. So some of the letters were saying, hey, you should go and get screened. And then some of the letters actually had lab requisitions in them saying, take this to the lab and get screened. So we were looking at which way people would, we would have the better uptake for people to be coming in and getting their kidneys screened on their own. And that was with Dr. David Collister, the virtual kidney check. And then Dr. Commenda helped us with the kidney check actual screening, where we would go into communities and do the screening in the communities. So this is another, what do you call those? Infographic that they have created with the Kidney Check Project and respecting the health and data sovereignty. So I'll let Cathy speak to this slide.
So this came about when in Manitoba, after 10 years of holding samples, the federal department that holds samples let the people know at Seven Oaks Hospital, which is where Dr. Commenda is based out of, and the Chronic Health Innovation Center, and they let them know that they were holding samples still from the finished project. And so they asked, what we wanted done with them. And so in terms of that, we still had the original people that had been involved in the finished project we're very fortunate. They're still working on the phase 1 and phase 2 of kidney check. And so the desire of the committee was to go back to those communities and ask them what they wanted done with the samples. And when they found out that the normal process, the process would be to incinerate them after 10 years. And so the communities that we were involved in the project, they agreed that could happen. But before that could happen, they wanted us to have a pipe ceremony. And so we had 2 elders come in from those communities. And we, along with the original doctors that worked on the kidney check project, were Dr. Paul Commenda and the late Dr. Barry LaValle, who passed away this year. And so we ended up having a pipe ceremony at the Chronic Health Innovation Center in their garden. And so we had this ceremony, and Tannyce and I were involved in the ceremony. And for me, it was one of the most moving things that I've attended in a long time. And so what we did was that we went around and we had a conversation. We talked about what would happen. And then through this, we actually had this wonderful graphic created. And all of this was done with the communities that were involved and the people that were involved. In terms of that, we had everyone's approval to proceed. And so this was developed by the KIM organization under the direction of Dr. Barry LaValle, and FINISM and CHR under the direction of Dr. Paul Commenda. So this is the graphic that we presented in terms of respecting health and data sovereignty in terms of how to do things in a good way. And I urge you to, I believe it's still on the website of Kim. I've presented this in about 3 different forums at the Canadian Society of Nephrology, presented it at the Data Sovereignty Conference held by First Nations Health and Social Secretariat in Manitoba last year. And it's something that we know that in terms of data sovereignty, that we have to continue to do this, to go back to communities to be able to do things in a good way.
Thank you, Cathy. So if you can just go back a couple of slides there. So when we first started doing the kidney check project, we were all set and ready to go, and then COVID hit. Sorry, that's when the pictures of the walk, Jocelyn. So what we wanted to do is increase the awareness around kidney disease and the numbers, because a lot of people are not aware of the numbers, and a lot of people that we spoke to thought, well, I don't have diabetes, so my kidneys are fine. So we really wanted to increase awareness around kidney disease. So we held a kidney walk in 2024. And we had 25 different First Nations communities participate in that walk. So we had it all on the same day. We sent out these green t-shirts to everybody to participate. We sent out little signs to put along the walk path, just saying, 1 in 3 people, if you're First Nations, 1 in 3 people are at risk of kidney disease. And it's really get your kidneys screened, that type of thing. We had those all along the pathway just to increase awareness and knowledge around kidney disease. I can't tell you how many times I've been in a screening event. You can see on the bottom there, myself and Charmaine sitting at our kidney check table, getting people to come in and get screened. And we're like, hey, come over, come and get your kidneys screened. They'd be like, I don't want to know. And I'd be like, yes, you do. Yes, you do want to know, because there's so many different medications and things out there that can help and prevent kidney disease needing dialysis. So that's one of the most important things for us, I think, was really increasing awareness around kidney disease and how you can prevent and delay dialysis just by doing a simple urine and blood test. So we'll go back to where we were there, Jocelyn. So yes, this is the 6 R's of the Indigenous community engagement that the IPERC group has used in their ways of knowing and doing things in a good way. So making sure that using these 6 R's, respect, relevance, making sure that it's something that this community actually is concerned about or needs more information on. Being able to give back and forth and having a true partnership. So, it's not only the researchers who are gaining something from this, the community has to be able to have something gained from it as well. And just respecting those relationships and being able to reflect back on the work that you've done, and then putting that reconciliation into action. And really engaging that community and making them the important part of the project that they actually are. So some of the lessons learned and challenges. So we know that community engagement takes time. It really does make a huge difference, though. Building that relationship before you even get into the community is huge. Some of the communities that we got into, there was just so many other things going on. There had been a couple of, I think 3 young people had committed suicide within a month, and then they had a couple of other really terrible things happen in their communities. And we were screening in that community at that time, and there was nobody coming in, but like, what can you do? The last thing that a lot of people are thinking about right now is with their kidney health, when there's so many other things going on in the community at that time. So there was a lot of risk of trauma. So like having a teenage kid come in there and then having to tell him that his kidneys were quite sick. That was something like we really had told ourselves we really needed to train more. So the nurses took a lot of extra training on talking with kids and working with kids and making sure we're doing things in a good way there too. We had tons of challenges with our reagents and our materials, with our fridges. Say if our fridges broke down, we would lose like thousands of dollars worth of supplies and stuff like that. So that happened a couple of times, and that's always kind of an ongoing challenge with our group. So yes, so some of the challenges that we learned in the kidney check project. So the patient partner health risks involved in travel outside their own community, because We do the researchers. Sometimes it is a lot, like with the patient partners having to do a lot of travel and go to a lot of different events and stuff. It can be quite tiring. So we have to make sure that we're taking that into account as well. But then we have to always make sure we are paying attention to the successes as well. So looking at that community-led program, making sure that the community is involved in their wellness approach and self-determination. We have really fine-tuned, I would say, the screening process. We've been working really closely with the pediatric nephrologists in Manitoba and really trying to fine-tune the screening process for children so that we can start screening our kids in the best way possible, and hopefully reducing the amount of First Nations people in dialysis in Manitoba. Did you want to add anything to this one, Cathy?
No, just in terms of the process and that, like one of the first things we do is we send a letter to the community, to the chief and council, and we ask them if they're interested. And even before that, we've from the Finish project and phase 1, we've created a bit of a heat map. So we know areas of Manitoba where the burden of kidney disease is really high. And so we try to pick a large community. We try to pick a smaller community. We also pick a drive-in community, a fly-in community, a rural community. We try to make sure that we're covering as much as possible in terms of what we do, and then from there, patient partner and the team goes out and talks to chief and council, and then we take it from there. Do they want to proceed with screening? When do they want to do it? Who's going to be our contact in the community? There's a whole process that we have to go through in terms of, we always have the community with our resources to be able to supply the lunch and do they want us to come in and do a bit of a health fair first? Tannyce and her group at Finism do a lot of healthcare fairs in the community, so we kind of spread that knowledge out in terms of things, and then we go into the community and screen. We try to always make sure a patient partner is available to go to the screening, and in case so there's some questions and different things going on. And once the screening is done, we make sure that we provide that information back to the community, and most times when we leave a community after, they want us to come back. They want us, they've realized that, they need more screening in their community, and how can we get this done? I don't think there's been many communities that have said to us, they want us to come back and that. And one of the other things that I have to add about Tannyce and her team at Finism is they also do community events. Like when there's a large community event a large Indigenous event. They did a hockey tournament. They did a hockey tournament recently. So when there's a large gathering of people, when the medical directors come in and that, it's always helpful to have the medical directors and also to have the leaders in the community. Oh, I apologize. I just lost my thing. To have the leaders in the community be able to do the screening. So, there's a whole host of things that happen behind the scene, and Tannyce and her team work quite closely with Seven Oaks to be able to do an effective job. So we've got some information at the bottom. In terms of if anybody wants to know information, and I see that someone put treaty days, and I know that Tannyce and them have gone out to communities and done and had a booth and had everything at treaty days and screened people, because it's about creating that awareness of kidney disease and how important it is to get screened. Aho Megwich. Any questions?
Thank you so much for the amazing presentation. One question in the chat about next steps for Kidney Check project.
So with the Kidney Check project, the screening is all done now. The funding was finished at the end of November of last year. So I know there is some money coming into Manitoba, but it won't be for screening. It's more of getting the information out there and just planning, I guess, for further projects that will be happening in Manitoba. But the screening, as far as kidney screening with the Kidney Check project, that's over right now. So it's unfortunate, but we're hoping to expand because our services at the Diabetes Integration Project, so we do that in 18 communities. So we're trying to expand it so that this type of service is available in every First Nation community in Manitoba, but it's an ongoing funding battle.
Yeah, and one of the things that we actually have come to believe at Kidney Check is that it's a public health issue, and that people need to be screened. And there's been papers out in terms of the amount of dollars that are saved to be able to not only improve people's quality of life, but to be able to give that information, just the information and the awareness about kidney disease, which we provide in terms of the Kidney Check project, but also to be able to have people to have access to screening. We believe that that's a public health issue, and so we continue to knock on doors and see what we can make happen here in Manitoba, because we believe it's very important. Manitoba has the highest burden in Canada in terms of kidney disease. Kidney disease for non-Indigenous people, as Tannyce talked about, is 1 in 10 if you're non-Indigenous. If you're Indigenous, it's 1 in 4. And if you live in a rural and remote community, it's 1 in 3. So we really need to be doing more in terms of making sure that people are screened. I'm excited about the new medications that are out there because they've been proven to work, and we need to make sure that people are aware of them and have access to care. And that was the main thing about the Kidney Check, was to provide access to care and to provide access in a holistic way, and to work with our partners. We've trained nurses in communities to be able to do their own screening when available, and we found out that the best way to do it is for Tannyce and her nurses to go into the community and work with them and train with them. And then from this program, from this Kidney Check program, we also had, in combination with Red River College and the Kim organization, under the direction of actually Carolyn Chartrand, who was one of the original nurses on the, is still with the project and one of the original nurses on the Finnish project, put in a module in their diagnostic. They have diagnostic service workers, which are basically the healthcare workers or healthcare aides in the community, or even like healthcare representatives in the community. And so they take them into a program, and that they have incorporated the 12 hours of training of how to do point of care testing within the community. And that training and everything was developed from the standard operating procedures that Tannyce and her team, we had developed them for the Kidney Check, but her team has taken and enhanced those and updated them and continue to update them as we move along. And so the actual content for the program was taken from our standard operating procedures. And I believe to date that they've graduated 24, Tannyce?
I think so, yeah.
Yeah, and there's another cohort that's supposedly starting in September. So we're really excited about the reach and everything that we created within the program. Any more information, Tannyce?
No, I don't think so. I think that's it.
Good.
Thank you so much for this wonderful presentation and sharing sharing about this experience that you've done. It sounds like a great initiative. And looks like people in the chat hope that you can secure some funding as well.
Yeah.
We'll keep trying.
Yes, we will. We never give up. And the other thing too is that we're also looking for more individuals on our Cansolve team, on our Indigenous Peoples Engagement Research Council, and also on our Kidney Check project to just keep spreading that knowledge in terms of things. So you can get in contact with Jocelyn. Maybe you could post your information in the and Tannyce, your information in the chat, and we'll be able to help populate our teams and keep moving forward. Kidney Check is also going in BC, Alberta. We had a program within Saskatchewan, and also we're hoping to there's one in Ontario. So it's something that is national, and we really need to keep going in terms of that. And if you can't find any information, just go on the Cansolve CKD website, and we're all there. Miigwech.
Thank you. Thank you again, Cathy and Tannyce, for sharing your experiences and perspectives with us today. On behalf of the CDTRP Patient, Family, and Donor Research Forum, thank you both for your leadership, your partnership, and for helping us better understand how collaboration between communities, patients, and healthcare providers can drive meaningful change and improve health outcomes. I hope you have a wonderful day.